Good afternoon. Thank you very much for the invitation and the opportunity to present the views of the NHS on the reforms of the public procurement directives. I will say a few words about the NHS and public procurement in the NHS, then move into a short overview of the experience of the NHS with the current rules, and then talk about some of the recommendations for the review of the legislative framework, and end with some conclusions. About the NHS, the English National Health Service is one of the largest publicly funded healthcare systems in the world. We provide the vast majority of healthcare in England. It's based on universal access, free at the point of use, which means that differently from healthcare systems in a number of other member states, patients don't have to pay when they receive healthcare. We are the largest single organization in Europe, with an annual budget of above £100 billion per year, and with more than 1.5 million employees. We are currently undergoing a program of reforms, which may also have implication on the way public procurement rules will be implemented by the NHS in the future. A few words about public procurement in the NHS. NHS organizations are clearly public bodies, contracting authorities, so we have to comply with the public procurement rules when we purchase goods and services from the market. Around 1/3 of our budget it's used for commercial transactions, for relationships with suppliers. So out of a budget of just above £100 billion, around 34 billion is spent with commercial suppliers on an annual basis. If we take sort of typical NHS hospitals as a reference, we can say that a typical NHS hospital has a procurement budget of £72 million. And this is spent in the way that you can see in the slides, roughly. 23% in drugs, 32% clinical supplies and services, 7% non-clinical supplies and services, 17% in premises, buildings, 7% transport, 10% temporary or agency staff, and 4% in other suppliers. We consult NHS organizations on their experience with the current rules in light of drafting a response to the European consultation on the modernisation of public procurement policy, and we ask NHS organizations about their current experience, how they see their current rules. And the response that we receive is that the rules are seen as too detailed, complex, burdensome, costly. They take a lot of time and resources in the day-to-day of a procurement manager in the NHS. Sometimes NHS organizations or staff in NHS organizations feel that they don't have enough knowledge or skills in-house to deal with the rules, so they have to ask for legal advice to ensure that they comply with the rules, and therefore they limit the risk of legal challenges. This is particularly the case since the introduction of the Remedies Directive around 1.5 years ago, which made it easier for unsuccessful bidders to seek remedies in case they can demonstrate that procurers have not complied with the rules. So there is a general fear of legal challenges, which leads to a risk-averse approach, and as a result it hampers innovation in the NHS. You said before that innovation is really very important in our sector, and it is absolutely true. Innovation is at the key of what we do in the NHS, and sometimes we feel that the procurement rules are a little bit of an obstacle to boosting innovation in the ways that we would like. We also ask NHS organizations about views on how the rules should be reformed, and we received 3 main sets of recommendations from NHS organizations. The first recommendation or set of recommendations is very much about simplification and higher thresholds. As I said before, the rules are seen as too detailed, complex, So we would like to see the rules to become easier to comply with, to move towards a core set of rules which of course can ensure fair competition, but at the same time don't over-regulate, don't micromanage procurement processing and arrangements. We have also heard a lot of NHS organizations saying that they would like to see a significant increase in the thresholds. I saw some figures about the cost of running a tender in the UK, figures ranging between £37,000 for a simple tender and just above £220,000 for a complex one. The threshold is now at just above £100,000, which seems a little bit, in a sense, disproportionate if we look at the cost of running a tender. So one of the proposals put forward by the NHS organisation is either to increase the threshold or as an alternative route to move from the current criteria of the total contract value to a different criteria which is based on the annual equivalent value for contracts. Second set of recommendations, clarification. NHS organizations are often not clear on when they have to comply with the rules and how they have to comply with the rules. When they have to comply with the rules, for example, when NHS organizations are cooperating between themselves, the public-public cooperation, whether they have still to comply with the rules, whether there should be some, as a minimum, respect of the criteria in the treaty, non-discrimination, equality, transparency, or if they can just cooperate between themselves. Also, when there is not really competition in the market, when we think that only one supplier can in fact provide a service that we require, can we just award the contract directly, or do we still have to go through some sort of advertisement for this contract? So we would like to see clarification in a number of areas. One is certainly the one that we mentioned before, that I mentioned before, and some of you mentioned before, about the public-public cooperation when contracting authorities are cooperating between themselves. Another clarification is about Part A and Part B services. Health services classify as Part B, which means that they have only to comply with the rules in part. There is, let's say, a lighter regime. We support this in principle. There were different views in NHS organizations, but I would say that in principle we support a distinction for health services, applying a lighter regime for health services. But nevertheless, some clarification in this area would be welcome in the context of the review. Clarification also is needed in relation to some definitions. For example, the definition of substantial change to the contract. We would like to better understand what does it mean, substantial change, how far you can go, without having to retender again when you make changes to a contract which has already been awarded. And also, finally, clarification on contracting authorities. Which organizations are contracting authorities? We now move more and more to a provision of public services, which is characterized by a diversification of providers in the market. It's not that clear whether these organizations are contracting authorities or not. We move, for example, to a situation of encouraging staff to own their own organization and provide services to the NHS in the form of social enterprises. Are these contracting authorities or not? We don't know. We think that let's say, when the rule applies, the scope of the rules is not 100% clear, and we would like clarification on this.